Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on Apple Podcasts, Spotify, and on your favorite podcast app. Today, we're diving into the integral role of physical therapists within the interdisciplinary rheumatology team. Joining us is Dr. Yasser Salem, a seasoned physical therapist who will shed light on how PTs can enhance the care plans for patients with rheumatic diseases. He also discusses the optimal timing for referrals and the specific physical therapy interventions that show significant benefits. We'll explore the crucial role of patient education and the importance of communication between rheumatologists and physical therapists. We'll also discuss the common challenges that physical therapists face, advancements within the field of PT, and the future direction of physical therapy in rheumatology. Lastly, we'll learn about Dr. Salem's journey into physical therapy and his advice for those interested in this profession. Dr. Yasser Salem is a distinguished professor and program director of a Doctor of Physical Therapy program with over 20 years' experience as an educator. He's an active researcher, has published numerous articles, and has been invited to speak at conferences nationwide. Dr. Salem has also served in various editorial roles in prominent physical therapy journals, and has been awarded multiple prizes for his service, education, research, and leadership. Enjoy the show. Yasser, welcome to the show.
Thank you for having me. Hello, everyone.
So can you talk a little bit about what the role of a physical therapist is within the interdisciplinary rheumatology team?
Sure. Thank you very much for the questions. Physical therapists are licensed doctors of physical therapy who examine, diagnose, and treat movement dysfunctions. They work closely with rheumatologists, with physicians, other healthcare providers as well, in management of people with rheumatological disorders. They are trained healthcare professionals. They are considered movement experts. So if there is a movement disorders, that's where they can help. I believe they play an important role in non-pharmacological management and non-surgical management of rheumatoid arthritis or rheumatoid diseases in general. We see that they help people who have pain, acute pain, chronic pain. They help people with disability through designing a program, working closely again with the rheumatologist and other healthcare providers to help to address flexibility issues, stiffness that patients may have, endurance, rib conditions, strength, weakness. They help with bone integrity, coordination, balance, and also people who have risk of falls. Having mentioned, walking is a big issue that people with rheumatological disorders may have in addition to pain. So physical therapists, as movement experts, they help people walking as well.
I like that idea of physical therapists as movement experts because, one of the challenges in rheumatology is trying to figure out whom to refer to physical therapy because we see a lot of patients with mechanical issues like osteoarthritis. We see people with inflammatory joint disease, like you said, rheumatoid arthritis, maybe ankylosing spondylitis. And we also see people with chronic pain where there's maybe central sensitization happening in addition to perhaps some sort of mechanical involvement. Can you sort of help me sort out like which patient would benefit from physical therapy?
Sure. Patient with pain, because pain can be treated with many healthcare providers, including rheumatologists, but also physical therapists can use some hands-on technique using mechanical properties of the body to try to help. They have also some therapeutic modalities. What I mean by therapeutic modalities, not to get confused with pharmacological modalities. Meaning modalities in physical therapy, we need, meaning like ultrasound, like hot bags, ice packs, and other similar modalities. That's what I meant. So they are using their hands, just techniques to help people with pain. So patients with pain can benefit from physical therapy. Patients who have difficulty walking can benefit from physical therapy. Patients who has difficulty in movements in general, as I said, because physical therapists are movement experts. So if there is a stiffness, if there is limited range of motion, if there is lack of flexibility, people having difficulty to move because of weakness as well, all of those conditions will benefit from physical therapy.
Amazing. It sounds like most of our patients would probably benefit. And another issue that I often have is trying to figure out what to write on the script, because sometimes patients may have knee pain, but it may be a little bit unclear what the cause of the knee pain is, whether it's just osteoarthritis or maybe rheumatoid arthritis and osteoarthritis, or perhaps they have a meniscal tear. So to what extent does a rheumatologist or somebody that's referring people to physical therapy, do we need to have a perfect understanding of what's happening in the knee to refer patients to physical therapy?
In some situations, it's very helpful to have more description of the conditions because physical therapists may not have access to people imaging. When I mean imaging, X-ray, MRI, CAT scan. So sometimes it's helpful if you refer someone with a knee problem to identify specifically this is the patient has osteoarthritis versus have meniscus tear. Just let you know that physical therapists are able to examine, screen people as well for those conditions, but sometimes don't have access to imaging may really limit their abilities to confirm things. So having some description in the referral about that condition, especially if there is imaging or laboratory that were done, that will be great.
Excellent. That's very useful information. And then the other part of the referral, in addition to the diagnosis, is what to do about it. So to what extent do I need to say, oh, well, you need to try to do a muscle strengthening program or work with balance? Or should I just say, leave it up to you and say, evaluate and treat?
I like the latter one for a reason. Physical therapists, when they are in their school for education, they learn how to examine patients. They will learn how to develop plan of care. They also learn how to screen for possible referral if there is an issue that need to go back to physician, to rheumatologist as well. So leaving the plan of care to a physical therapist is helpful, unless if there is extreme very rare condition that there is certain precautions that's not the ordinary precautions. The standard precautions, all physical therapists are trained to know about it. This is a case of doing this kind of surgery. This is the precautions for this. This is a case of rheumatoid arthritis. They know exactly the limits that you cannot push beyond. Unless, as I said, if there is rare conditions that very come with its unique precautions, that's helpful. But in general, they're able to develop their own plan of care.
Got it. And then the other referral issue is in trying to think about a physical therapy versus an occupational therapy referral. Can you talk a little bit about when we should think about PT versus OT?
Yeah, that's a good question because there is a lot of overlap between physical therapists and occupational therapists. There is wrong assumption, and I believe it's wrong, that they say that the physical therapists are working with the lower extremities and the OT are working from.
Yes,
I don't believe that's exactly. But I'm not going to also speak about the role of occupational therapists because beyond my scope to talk about other people's roles and
Sure.
practice. But in general, occupational therapists are concerned about some upper extremity activities of daily living, like really dressing, undressing, cooking, and stuff similar to that. However, physical therapists are more concerned about walking, about turning in bed, about how to get up, how to do transfer skills, and so on. Stairs walking, indoor, outdoor walking, running, aerobic exercises, aerobic capacity, conditioning. Those are more towards physical therapy. And again, just there is a lot of overlap, although we say deconditioning and and aerobic capacity, although it's for PT, but it's also for OT as well.
Got it. And how do you see the role of a physical therapist in trying to help the patients understand their condition? Because, in rheumatology, our time is limited and, we may not have as much time as we would like to talk to patients about their rheumatoid arthritis or their osteoarthritis. How do you see your role in patient education?
Well, this is a great question because we know that physical therapists, one of their responsibilities actually to educate the patients. And I'll just let you know, there is a CPG, clinical practice guideline, that was published in 2021 in the Journal of Physical Therapy about role of physical therapists in people with rheumatoid arthritis. And most of their recommendation is about how to educate patients.
Wow.
So in general, in physical therapy, one important rule is how to educate patients. Educate patients about the disease itself, the disease process. So this is a rheumatoid arthritis per se. This is what's going to happen. This can be happening in the future. This is what should be doing to avoid and prevent what can happen or slow down the disease activity. So we educate them about the disease itself and the disease process and possible prognosis and how to work on prevention. Then we work with them and educate them in several activities and exercises that they can perform, because we are sure this is a chronic condition that will need a lot of exercises, and they're not going to have physical therapy for the rest of their life. So we're going to be for a couple of days or a couple of weeks, where one important thing is after we finish the episode of physical therapy, we need to make sure that the patient are educated about home exercise program, what they should do beyond physical therapy. So educating patients about, as I said, the disease process, about prevention, about how to improve their aerobic capacity, how to conserve energy, how to avoid activities that can exaggerate pain and stuff like that. Also, how to maintain their strength, their mobility, their joint mobility, flexibility, etc.
Yeah, that makes a lot of sense. I think one of the challenges with physical therapy is often we refer to patients for physical therapy. As you mentioned, it's sort of limited in time, and often they report improvements and then they stop physical therapy and sort of they go back to where they were. So it sounds like, there's a big role of what you mentioned, these like home exercises that patients should do. So for most patients, do you prescribe them homework for things to do at home in between physical therapy sessions?
Absolutely, because we know if we are approved or the physical therapist will be seeing a patient twice a week for an hour or 45 minutes, this is not sufficient to have carryover in most of cases. So we need to make sure that we supplement this with some home exercise program that patients will be doing on a regular basis.
Yeah, that makes a lot of sense. I know it's certainly hard. I've been to physical therapy several times for various injuries, and it's been even difficult for me to engage with all the heel lifts that I need to do for my ankle injury in between sessions. So I think that's challenging. Any advice in how patients can be more compliant with those home exercises? Like any tricks that you tell patients so that they're able to do these things at home without forgetting?
Sure. One important thing when we educate patients about home exercise program is we tell them why it's important. One of the things, if you give a patient a sheet of home exercise program and tell them to do it, there is high chance that they might not do it, versus if you, when you hand the sheet or before you hand the sheet and go over the sheet of exercises to make sure that they understand the value of home exercise program and how this is helpful. So understanding the value of home exercise program will keep patient motivated to do it. The other things is think about feasibility of exercise. We need to tailor the exercise program. We cannot have the same sheet of exercise program for someone who is very functional, ambulatory, goes to work without assistive devices and gives the same type of exercises to someone who that has more disability and sitting in a wheelchair most of the time. So that's both of them may not comply because you will see that majority of exercises in the home exercise program do not apply to them. So we make sure that we also tailor the exercise program. The other thing is to follow up. So after one visit, the second visit will come and talk to the patient again. Okay, tell me, what did you do in the last couple of days since last visit? What exercises did you do? What you didn't, and why? When the patients will see that you are really emphasizing home exercise program, they will start to understand and value the home exercise program, and that will keep them really more adherent to do it.
Fantastic. I've had many patients request aquatherapy. Can you talk a little bit about like which patients would benefit from aquatherapy as opposed to like land therapy? And certainly it's probably limited by access to pools. So how do you think about aquatherapy for patients?
Sure. This is one of the modalities that when I mentioned earlier about modalities that physical therapists can use really for people with rheumatological disorders, using aquatic therapy, aquatic exercise, as well as the other name is hydrotherapy. There is a difference between aquatic therapy and aquatic exercise. Aquatic therapy is done under supervision of licensed professionals, physical therapists, occupational therapists, and so on, versus aquatic exercises can be done by physical therapists, occupational therapists, and also other specialists. The evidence that we have showing good improvement and good results from using aquatic therapy. I'm currently serving as a director of research for the EPTA, the American Physical Therapy Association Academy of Aquatic Physical Therapy. And I was at one point the co-editor of the Journal of Aquatic Physical Therapy as well. So I got involved in this. I see the evidence. We have a good amount of evidence support the use of aquatic exercises and aquatic therapy for people with rheumatoid or rheumatic conditions. Aquatics, very similar to land therapy. There were just some differences that aquatics or being in the water temperature may help people with rheumatological disorders more than the air temperature. That's one thing. The being in the water can help to soften the joint stiffness, may allow range of motion because of some of the water properties. Aquatic therapy can help people who have limited weight bearing due to surgery if they have a surgery and have limited weight bearing. Actually, aquatic therapy can unweight the limb, so it allows less weight bearing as indicated after the surgery or so. So it really helps people with those issues. The challenge that we see, as you mentioned in early, that is just access to aquatics, access to the pool is the main challenge for using aquatics. But there are many evidence support the use of aquatics as possible modality for people with rheumatic conditions.
And, I often think about aquatherapy also in patients that have autonomic dysfunction or POTS or issues with like maintaining their blood pressure. Is that another, potential benefit of aquatic therapy for these patients?
It is. It helps with some of those autonomic functions. You just need to be careful to which patient that can be really involved in this. There is an article that published, I was one of the co-author about exercise in general for people with myositis or let's see, immune diseases in general. And we wrote a part about aquatic therapy and how can also help. And there is preliminary evidence that aquatic exercise can help also autonomic dysfunctions in people with autoimmune disorders.
Amazing. How often do you communicate with the referring doctors when you're seeing a patient, that was referred to you for rheumatoid arthritis or osteoarthritis? What's the importance of that communication between the rheumatologist and the physical therapist?
It is very important to communicate with the rheumatologist and other healthcare providers involved in the care of that particular patient. Now we know that now we're going into what we call interdisciplinary practice, but also interprofessional practice as well. So we see that the more, and we have evidence of that, that the more that healthcare providers communicate and speak to each other, that will be helping the patients and will benefit patients and also will be cost effective more than just lack of communications. Communication will vary based on individual basis. Patients who are very stable, we see less communication, but people who have either serious conditions or there is rapid changes in the status, that's where we see more communications.
Yeah, I've certainly had physical therapists reach out to me saying, patient's not doing well. Or, for instance, I send them for their left knee, but they think that it's the right hip that's most involved. And that's been incredibly helpful, getting, another pair of eyes, onto the patient and trying to help out, figure out what's going on and maybe, put in some additional therapy options for that. What would be the best way for a rheumatologist to reach out to a physical therapist, about a change in plan? Or, yes, we were talking about the left knee, but, I think it's the left hip. And, we found that the patient has like a labral tear. What would be the best way of communicating those new findings with the physical therapist?
Well, from the rheumatologist, it's helpful for physical therapists to learn about any new changes, new development in the patient conditions, as you mentioned, that the rheumatologist can just make sure that this communicated to the therapist or physical therapist, but also physical therapists should, and they learn it in their education, to refer or to communicate back to rheumatologists or referring physicians if there is, as you mentioned, no changes in the status. So if there is, you apply the treatment and no changes or no improvements, there is no response, you don't have to carry over. Just make sure that you communicate with the referring physician that no changes, what can be possible causes. The other thing that physical therapists are educated to do is actually examine and screen patients. And the more they communicate with the referring rheumatologist about anything that have discrepancy or not included in the referral, it's helpful, as I said, working as a team to come up to conclusion about what really is happening here. Is it really a knee issue? Is this pain or this walking difficulty? Is it a knee issue? Is it a hip issue? Is it both? Or really it's both of them. So it is very important for physical therapists when they see a little bit discrepancy between their findings and what's written in the patient's report or referral to communicate back to the physicians or referring rheumatologists. The other thing, if there is a change in the status, and this happens very often, that you start with something, then all of a sudden you will see that if there is some new development and may indicate that this patient needs further examination by a rheumatologist. This is where we make sure also that we communicate back to the rheumatologist about those things.
Fantastic. And are there common strategies that physical therapists recommend for people with like rheumatoid arthritis or other rheumatic diseases to help them, maintain their daily activities? Is there something that you think would benefit most patients with rheumatoid arthritis or other rheumatic diseases?
Yes, that's a very good question, because what we do as physical therapists, we educate patients about the disease and this disease process. So one of those education is to make sure that we work with the patients on how to be able to perform EDL given their current status. So we educate them how to avoid things that trigger pain. That's just the example. Unless you have to do it, but if there is possibility to modify the activities that they do, how to conserve energy, because fatigue is really a big issue with people with chronic conditions, including people with rheumatic conditions. So make sure that we teach them how to conserve energy, how to arrange their daily routine, what should be done, what should be minimized, what should be avoided, what should be modified, and so on. That's another strategy. How to address pain if it happens, especially if it's limiting the EDL or ability to limit EDL. What kind of exercises that you should focus or emphasize in so that can help the limitations in the ETL.
Yeah, that's great. I didn't think about fatigue as an issue that physical therapists manage, but you're absolutely right. It's very common in many rheumatic diseases, and I'm glad that's something that physical therapists have on their mind and are addressing with their patients. Are there specific challenges that physical therapists face when managing, patients with rheumatic diseases? And, what are some ways that you guys look at those challenges and try to overcome them?
We know that people or many people with rheumatic conditions end up by having chronic conditions. So that's just working with people with chronic conditions who have been in pain for a couple of years.
Yeah.
That really is a bigger challenge. Also, the other challenge, if there is any really secondary deformities, for example. So some people with rheumatic condition like rheumatoid arthritis, at one point they may develop some deformities. So that's, again, being a challenge. To minimize this challenge, we need to make sure that early on, we work with the patient and educate them on how to avoid this. This is going to happen. You need to avoid it. Give them some activities, some home exercise program, some precautions on things that they should do and shouldn't do to avoid those challenges in the future. So I see pain is a challenge.
Yeah.
Being in pain for long period of time, that's a challenge. See, the secondary complications, which is the deformities, is a challenge. Having limited flexibility and range of motion, stiffness, which is secondary problems, that's another challenge, and that can be preventable or at least can be slowed down by, again, exercises and educating patients about how to avoid those.
Mm-hmm. Fascinating. You mentioned before that you've been involved in research. What are the main questions that physical therapists are trying to answer? What are the big topics that physical therapists are engaged in researching in these days?
There are many areas, but I'll limit my talk to rheumatology in general. Just what is the best strategies? What is the best type of exercises for people with rheumatology? But more important, the dosing itself. So it's not just a type of exercises, but what is the best doses? How many times per week patients need to exercise for how long? We need to balance this very well because we know some people with rheumatological disorders, they end up by having a fatigue, deconditioning. So how much is too much or how much is too little? And what is the optimal dosing? When I talk about dosing is one, intensity of exercises. Because if you do too intense exercises, sometimes it may hurt and not benefit the patient. So patient can come to a fatigue, soreness, and take them some time to recover. That may exaggerate pain, so turn it up to be a negative versus really helpful. And if we do too little exercises, they might not get them into the potential and may not really help them much. So we have to balance intensity in terms of dosing. How many times per week? What is the optimal dosing? How long is each treatment session can last for, or even the patient doing home exercise program? How long should the patients continue to do exercise daily? I believe those are areas that need really research.
It was fascinating. Just yesterday, I was speaking with one of my friends who's a wrestling coach. And we were talking about this question about dosing for just, overall health. And he was telling me about this study where they showed that high intensity exercises for just a few seconds at a time, right, repeated, over 5 minutes can provide you, as much benefit or more than going to the gym for like 45 minutes of doing regular strength training. It's so interesting that, that idea of dosing and frequency and intensity is also faced by physical therapists these days. So what do you see about, the future of physical therapy, especially as it relates to the care of patients with rheumatic diseases? Where is the field headed?
Oh, that's very good questions. We see that patients with rheumatological disorders, as I mentioned, they seek care of many healthcare providers. One of the things that people are talking about are physical therapists are able to do direct access or be a primary care providers for people in general, including
Mm,
people with rheumatological disorders. Can they see them? And can they prescribe imaging for them, which is really
mm,
limited at this time. But this is one of the things that people start to talk about it for a couple of years, and I see this is became a trend at this time. Is can physical therapists be a primary care provider for some people with chronic conditions?
fascinating. What do you think about the role of virtual physical therapy? Does that work? Is that in place in some areas? And for what type of patient would that be useful?
I think it's useful. We learned it a lot from from COVID time,
You're right.
where patients are not able to access physical therapy, where physical therapists can provide telehealth. However, we need to consider also with this couple of things. One is there are some conditions will require really hands-on techniques. They
Hmm.
require physical therapists to have their hands touching the patient's body or part of the body, the knees, the back, and so on. And those in reality cannot be substituted by telehealth
Mm.
or virtual visits. However, there are some kind of exercises or type of exercises can really be supervised and can be performed virtually, as you mentioned. The other things also is more legal issue is how physical therapists who live in a state of California can provide virtual reality session to people who lives in New York per se. Does this physical therapist have a license to practice with a patient in New York? So there is a liability issue and legal issue here, but there is also a scientific issue here.
Yeah, yeah, it's so interesting. I mean, those are the same issues that rheumatologists face, right? You mentioned the hands-on approach, especially when evaluating new patients and you're trying to determine whether, the joint is swollen or not. Like you need to see that patient in clinic and you need to push on their joints. But for patients that have already been diagnosed and are doing well, for patients with gout or other conditions that, the physical exam may not be so useful. I think virtual care has been a godsend for patients with rheumatic diseases. And also the issues you mentioned about licensing and I can see a patient from New Hampshire when they come here, but if I try to do a telehealth with them in New Hampshire, it doesn't work. But if they just drive 10 minutes south and they cross the border, then I can do it
Yes.
from their cell phones. It's really silly. And I think those license requirements probably need to be updated, to the
Yeah.
21st century. Just a couple other questions. How do you see the role of the ACR and the ARP in helping to provide, adequate physical therapy care for people with rheumatic diseases?
That's a good question. And I see this happening already that they are providing more information about the role of physical therapy and physical therapists in the website. I see new documents that came published recently about not just physical therapists, but I like that they came with many healthcare providers in that documents other than physical therapists. So promoting the role, informing healthcare provider about the role of physical therapists and what they can do and how they can help when benefits of physical therapist having patients with rheumatological disorders is helpful for referral. It's helpful for the patients as well.
And one last question. There may be people out there that, get excited about everything you've mentioned about becoming a physical therapist and becoming, as you mentioned, a movement expert. How did you get into physical therapy and what tips or recommendations would you give for other people that may be interested in pursuing a career in physical therapy?
Sure. To be a physical therapist, individual must complete a doctor of physical therapy program. in US accredited program and also received a license. There's a license that they have to pass or pass an exam for when they complete their DPT or Doctor of Physical Therapy degree. Just to let you know, to be complete a Doctor of Physical Therapy degree, students need to complete almost between 2 to 3 years. It depends on program of education following a bachelor degree in a DBT accredited program. After that, they should be able to sit for an exam to practice physical therapy. One of the things that I usually advise candidates when they approach me about Doctor of Physical Therapy program is first is to see if this is a career you would like to be in for the entire your life and your career. So shadowing a physical therapist or more than one physical therapist in different settings will be helpful for them as a starting point to know exactly this is a career that I'd like to do. Especially in physical therapy, we see many settings. People are working in a hospital, people working in rehab hospitals, people working in military, in outpatient clinic, people working in a school system for children with disability, people working with the children 0 to 3 or early intervention. So there are many settings that people can really shadow a physical therapist or more than physical therapist to know this is their career. The other advice is that for those interested in physical therapy is really to find a mentor, a physical therapist who can really help them in how to prepare their education, or even not necessarily to be a physical therapist, a clinician, but also can be advisor from academic institution that has a Doctor of Physical Therapy program. Is how I prepare my undergraduate degree that really helped me to get into physical therapy, or what courses do I need to take to help me to get into physical therapy. And one thing that physical therapy programs are looking for in their candidates, as I said, your major, your degree, your GPA, that really will be helpful to have a mentor that can advise students.
Yeah, and I'm sure there's a huge need for physical therapists. Oftentimes we refer patients and they tell us, we see the patient 3 months later and we're like, how did their physical therapy go? And they're like, oh yeah, I'm booked, for September. So there seems to be just like a shortage of rheumatologists, a shortage of physical therapists. So if we could get more people interested in physical therapy and becoming physical therapists, I think that would be great for everyone. Yasser, thank you so much for your time. This has been a really great and enlightening conversation about physical therapists, and I really appreciate your time. Thank you so much.
Thank you very much for having me.
Well, if you didn't know it before, now you know the crucial role that physical therapists play in the care of patients with rheumatic diseases. From enhancing patient care plans to providing essential education, I think their contributions can be invaluable. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. You can find our show notes for this episode at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep making those PT referrals. And of course, stay healthy.